Just continuing the previous IC, it was one of the most super hit IC from last couple of years. So we'll be dealing with troubleshooting unhappy cataract patient. We have got quite interesting topics. I request all our co-instructors, Dr. Vikram Jain, Dr. Sunil Ganekal, Dr. Sharath Hegde, Dr. Abhishek Jiu, Dr. Shaman Shetty to be come to the stage. So this is a very interesting IC. So what are the problems you will have the patient with unhappy cataract surgery patient? So we'll start with first with unhappy patient which is associated with ocular surface disorder. Over to you, Dr. Abhishek. You can load it.
This topic for discussion is associated ocular surface disorders in unhappy cataract patients. So cataract patient is truly satisfied only when his ocular health is very good. Many of times we come across patients who, in spite of having an uneventful cataract surgery, still complains of pricking sensation, stinging sensation, some foreign body sensation, even though there's no obvious ocular surface pathology. These are the patients who have unhealthy ocular surface. And these ocular surface abnormalities are commonly seen in elderly population, and fortunately or unfortunately, it is these subcategory of population that presents to us for cataract surgery. And this not only affects patients symptomatically but also affects their refractive outcomes. So why does ocular surface get affected following cataract surgery? Various factors like repeated drying and irrigation that occurs throughout the procedure of the surgery, various eye drops that are instilled, the phototoxicity from the light of microscope, surgical trauma, be it placing a speculum, making an incision, holding conjunctiva for support, or placing a flak suction ring, all cause microocular trauma which damages corneal epithelium and goblet cells, resulting in dry eyes. So again, the literature suggests the same. And how do you work up these patients on the lines of ocular surface? We start with symptoms. We ask the patients how they feel. A simple method is to offer them a OSDI questionnaire that has simple subset of questions regarding their symptoms, and then grade them accordingly as normal, mild, moderate, and severe. So once we understand the symptoms, the next thing is to examine them on slit lamp, look for obvious pathologies like lid margin abnormalities, any foamy discharge suggesting MGDs, telangiectasias, or obvious evidence of dryness. Bedside investigations like Schirmer test and tear film breakup time can also be helpful in assessing the ocular tear film surface. So why this has to be done? Studies have again pointed out that tear film breakup time and Schirmer tests are drastically affected following cataract surgery. Not just immediately, even after 1 month, it seems to be affecting the tear film breakup time. So once we have seen the ocular surface clinically, we'll dig a bit deeper and go into imaging. Meibography, I think, should be incorporated in every setup because now that we practice premium cataract surgery, even if one does not have sophisticated machines, one can always look at meibomian glands through simple AR machine and look for any gland dropouts or meibomian gland abnormalities. Why? Again, because a lot of patients presenting for cataract surgery do have significant meibomian gland dysfunction, and many of them are in fact asymptomatic, and us doing cataract surgery on them is just worsening the MGD. So MGD will cause definitive ocular surface discomfort and suboptimal visual outcome, resulting in unhappy cataract patients. Now that we have all incorporated aberrometry in our premium practice, the most commonly used aberrometer, that is the iTrace, has in its latest version something called as tear film analysis. It scales the ocular tear film objectively on a scale of 0 to 10, 10 being good and 0 being the worst. It also gives an objective tear film breakup time, and it is called as topo breakup time, which is the first point at which the Meyers get disrupted. The next most common ocular surface parameter that gets overlooked is epithelial thickness. Epithelial thickness is a surrogate marker for ocular surface health. Irregular epithelium can result in poor healing and nerve regeneration and ocular discomfort. Now that we do OCT screening for all patients, a simple OCT has an epithelial thickness mapping which can indicate irregular epithelium to take over such category of patients. Now that we have imaged how to treat these patients, first categorize them symptomatically as patients with asymptomatic, mild and moderate symptoms or severe symptoms. Then depending on the imaging, if they do not have any gland loss, they do not have any irregular epithelium and tear film index is quite good, then it suggests a simple aqueous deficient dry eye, and all we can do is lubricating drops. Next, if there is some amount of gland losses, let's say 25 to 50% with a regular epithelium, but a tear film index relatively low of around 5 to 8, then along with lubricating drops, we can add topical corticosteroids and cyclosporins, because ocular surface inflammation is an overlooked topic when it comes to ocular surface abnormality, and we need to take care of that as well. We even have to start them on omega-3 fatty acids, which would improve the meibomian gland outflow. Suppose they have significant gland loss, more than 50%, with irregular epithelium and tear film index less than 5, then these patients will not just improve with topical therapy and will need a procedural dry eye therapy. What are procedural dry eye therapies? We'll look into that in future slides. So in a gist, ask the patients to maintain lid hygiene, start them on preservative-free eye drops, and review them on regular intervals as per your need. In case they do not improve, then treat them with procedural dry eye disease therapy. To add a quick note on them, it may be light modulation therapy or intense pulse light therapy, or something with mechanical effect as well, such as LipiFlow. All these does is improve meibomian gland outflow and hence enhances tear film stability, in improving ocular surface and better patient outcome. So among these, LipiFlow, usually we need to wait for a month or so, because this has small pressure effect, so early post-op patients might not be good for them to undergo LipiFlow patients. So overall, ocular surface disorders do take a huge chunk of patient satisfaction away from your patients, and they can exist in the absence of any clinical evidence signs. Optimizing ocular surface is very vital for enhancing post-op outcomes. We need to tell patients that all these tests are not being done to overburden them, but rather to enhance their refractive outcome and their symptoms. So treatment should ideally begin in the pre-operative phase, because we've all seen that meibomian gland deficiencies are significantly present in cataract patients, and once we do surgery, we just overburden them with more ocular surface abnormality, and we should treat them pre-operatively to prevent such things from happening. Thank you all.
Thank you, Dr. Abhishek, for an excellent talk. So it's very important. Once upon a time, I think Vikram, you can load your presentation. It's very important pre-operatively. Once upon a time, whenever the cataract patient comes, most of us jump in for cataract surgery. But I think doing a dry eye evaluation is at most importance, because most of the unhappy patient, if you see, around 80% of the unhappy cataract patients are due to the dry eye issues. So if you can tackle them, you need not have to have actually what Dr. Abhishek said, that of whether any of the LipiFlow or even with the IPL treatment. Rather, once you know that the patient is having the very severe dry eye or meibomian dysfunction, treat them, even treat them with the doxycycline. Then also you can start them on a cyclosporin 2 weeks before. Then you can go for cataract surgery after 2 weeks. That really makes sense. So I think in the end we'll have different talks why patients are having unhappy. Then we'll come to one final conclusion how to tackle each of them. Now Dr. Vikram Jain is going to talk. He is the Chairman Scientific Committee, Karnataka Ophthalmological Society, also fabulous phaco surgeon. So he'll be talking about how I deal with dysphotopsia. Over to you, Dr. Vikram.
Thank you, Dr. Kudlu. So let's discuss about dysphotopsia, the types, and how to go about doing this. Our entire session is about a good surgery but unhappy patients. Why? Dysphotopsia is one reason. Now, when I'm talking about dysphotopsia, I'm not going to highlight about the halos that we see in multifocals or trifocals, because we all expect this pre-op. There can be some unexpected changes, unexpected symptoms post-operatively. Let's try to look into what they can be, why, and how to go about them. So dysphotopsia are undesirable and subjective optical phenomenon. They are subjective. There are no objective tests to detect or quantify these. They can either be positive or negative dysphotopsia. They are only diagnosed when the patient complains of them. There are no objective tests. It is important that we distinguish these symptoms from probably some retinal vitreous traction which is producing some flashes, or a striae in the posterior capsule which is giving the Maddox rod effect. So make sure it is not these, and there is something else, other symptoms which we can't attribute to anything else. Positive dysphotopsia is when patient complains of seeing excess light, extra light, Negative is when there is a dark shadow. There can be different types of positive dysphotopsia. The common ones are the arc, which is when the patient perceives the edge of the IOL. This happens with a bigger pupil size, so therefore after evening. It generally recovers over time, especially if the capsule has overlapped the IOL edge, then this arc decreases within a few months. Flare comes with minor cylinders and a coma. Correcting this very minimal cylinders 0.25, 0.5 also helps in these patients. Later on, once the patient adapts to it, these glasses may not be required. For all these positive dysphotopsia, making the pupil smaller at night definitely helps. Central flash is when the patient suddenly sees a glare because of reflection, internal reflection at the edge of the IOL. So you have the internal reflection there at the edge, which comes as a glare, sudden central flash. The patient might perceive that. Starbursts are caused because of backscatter, again a form of internal reflection from the lens, along with some eye movements which trigger these. Halos I already told that I'll be skipping it because we know why they occur. That's because of differing refraction at each edge of the multifocal IOL. These positive dysphotopsia are seen more commonly with square edge IOLs. Oval optics, which are now, I think there are some Indian innovators who have come up with the recent oval optic. Earlier, Masket had an oval optic which was then abandoned for this reason. Also with higher refractive index like the IQ is very, very prone to positive dysphotopsia. To overcome these, manufacturers made some changes. There was a rounding of the anterior edge and lenticular design. So here you see a much thicker IOL. In lenticular design, the edge of the IOL was thinned out. These definitely helped, and the positive dysphotopsia numbers dropped. How to manage these? If there is any refractive error, I told you about the coma, correct it. If there is PCO, treat it. Otherwise, a YAG would never help. Meiosis in the evening, just a single drop of pilocarpine every evening initially will help. In case of high refractive index lenses, you might have to exchange the lens in case it is not coming down. What is negative dysphotopsia? Negative means that the patient is not seeing something. There is a dark temporal crescent. This incidence is very high initially. In the first 2 weeks, generally the patient has the wow effect immediately after surgery. When you see him on the third or fourth day, the next time he comes, he'll start complaining about the temporal dark crescent. Why is it temporal? There are two schools of thought. One is because the nasal retina extends a little more anterior. Other one is that the bridge of the nose cuts off the light coming from the other side. Now these negative dysphotopsia will be worsened by constricting the pupil, whereas positive, I told you, you can constrict the pupil, therefore don't constrict the pupil for a dark shadow. This negative dysphotopsia is associated with any incision, temporal or superior. It is associated with any IOL which has been placed in the bag. It is not seen in sulcus or AC IOLs. It is not seen in poorly centered lenses. Basically, if a patient is complaining of this negative dysphotopsia, it's a pat on your back that you've done a anatomically perfect surgery. It is seen only in anatomically perfect surgeries. Otherwise, if it's imperfect, if the IOL is not centered, this is not seen. It is seen more commonly in higher powered IOLs as well as lenses which I already mentioned, higher refractive index. So this is how the patient would complain. There is a dark shadow. This is a left eye operated, so on the left side there is a dark shadow on the temporal aspect. There were two schools of thought as to why this is happening. Holiday said this is an edge penumbra, and Masket said it is because of the relatively deeper IOL. So this is an edge penumbra wherein there is some refraction happening, some reflection happening. So there, like an eclipse, you are seeing the dark area. Again, with round edge lenses, this penumbra is thought to be less, but then this negative dysphotopsia persists. That's why Holiday came up with his theory about the position of the lens. So here this arrow is showing that how the internal reflection occurs, and therefore there is a penumbra there. So what Holiday said was that because of this distance, the anterior capsule is supposed to be here. Earlier there was not much of distance. Now it is much more, the distance there. There are unrefracted rays going through. So because there are unrefracted rays going through, you have this area with no light falling there. So how do we surgically manage these patients? One is to put a piggyback IOL in the sulcus, you are going to be cutting off some aberrant light pathways there, or doing a reverse optic capture by getting the optic into the sulcus, keep the haptics in the bag itself, or reposition the entire lens in the sulcus. Holiday also had had designed a dysphotopsia IOL with a small edge there where the anterior capsule goes and sits there, so that the lens is maintained little anteriorly. But most of the time, masterly inactivity is the best. In my initial slide, I showed you that 35% of our patients will complain of this at 1 month, but it decreases to 3% by the end of a year, and even lesser in longer follow-up. We all don't see our own physiological blind spot. There is natural backscatter of the natural lens which we don't perceive, as well as the retinal blood vessels. We adapt to all of these. Similarly, this negative dysphotopsia also disappears with time. Very, very rarely do patients complain about this over a period of more than 1 year. Thank you.
Thank you, Dr. Vikram. I think most of us really were confused with the glare and halos with the dysphotopsia. So we tend to give them lubricating drops. We tend to give them, of course, we always wait for the neural adaptation to happen. In your case scenario, do you have any patients with the dysphotopsia? Really, you had a chance of explanting the lens?
Not really. I've not explanted a lens for the dysphotopsia. As you said, lubricant will work if to correct any ocular surface, and most importantly as a placebo. The lubricant will act like a placebo. They'll think that, okay, doctor is doing something, he's added something extra, and when it gradually decreases, they will also stop complaining about it.
Yeah, we for every patient, you have to give a time for neural adaptation. See, you have seen patients with complaining of this kind of starbursts and all, but after 1 month they'll tell, "Pehle se thoda kam ho raha hai." Then when they come for a second follow-up after second month, they'll tell, "Now I am getting better because of drops," as you said, that placebo. And the most of the time, 99.9% of the patient, after the end of 3 months, they say that now I'm absolutely all right. So you have to give, and I think counseling is at most important. There is slight change in the order because of Dr. Sunil Ganikal, who is has to go for other hall. He will be talking something about the capsular contracture and capsular distension syndrome. Dr. Sunil Ganikal has been our past chairman scientific and also editor general Karnataka Ophthalmic Society. Over to you, Dr. Sunil.
Thank you, KP, for the introduction. Let me talk about some of the common problems which you face with respect to the capsule, that is capsular contracture and capsular distension. See, whenever you aim for a perfect cataract surgery, we want a perfect lens centration without any IOL tilt or a pristine optical quality. Usually, shrinkage of the anterior capsule occurs much earlier than the PCO. How can one identify the capsular contracture is by thorough slit lamp examination. One can dilate the pupil, direct visualization under slit lamp. If you see the change in the effective lens position, that gives a clue that patient may having a capsular contracture. Then result in shift in the refraction. If you see in the post-operative period, then could be due to the capsular contracture. What it causes is basically it obscures the vision. Progressive contraction sometimes leads to the IOL capsular bag dislocation. Especially if you are using a presbyopic correcting IOLs, these contractures can bring about decreased vision, which is sometimes irreversible. Best form of prevention is to taking care of all high-risk patients and avoiding this capsular contraction. What are the risk factors? The one could be pseudo-exfoliation patients, uveitic patients, degenerative diseases like retinitis pigmentosa, eye myopia, advanced age, trauma, diabetes. All these are some of the risk factors for causing capsular contraction. Does creating a large CCC will have any benefit? Definitely, creating a large CCC will not prevent the capsular contracture, but in spite of contracture, we will have a clear optical quality through because of the larger opening in the CCC. Removing of anterior epithelial cells sometimes can help, but difficult in obvious zonular weakness. Care must be taken. Sometimes if you over aggressively do it, you may damage the zonules. What about the IOL designs which contributes for the capsular contracture? More seen with the silicon plate IOLs than the acrylic. Prolin haptics tends to have a more optic capture. There is not much difference between single piece and 3 piece. There is a debatable issue. The square edge optic design preventing a PCO than so square edge designs may prevent a PCO, but with respect to the capsular contraction, not much of benefit. But one should carefully consider in presbyopic correcting IOLs, all these things you should choose a proper IOL and to avoid these complications. CTRs Definitely, I would recommend how much ever the CTRs ideally should be sutured. CTR alone sometimes may not prevent the contracture. In high risk cases, you may have to use a CTR or a CT segments and you fix them to the sclera to use a perfect capsular supportive bag which prevents the contraction. So in all high risk patients, better to use a sutured CTR or CT segments than just pacing a CTR. This is a case which shows that due to the anterior capsular contracture, there is a posterior vault of the IOL, the AC depth has increased. So simple maneuvers like NDAG laser relaxing incision on the anterior capsule can take care of the capsular contracture. You have to give a radial incisions, 4 radial incisions, starting from the optic edge. Try to avoid hitting the haptics. If you go radially and create a nix like a snips like relaxing incision, usually the capsular contracts tends to overcome, and YAG is a simple maneuver with which you can minimal contractures can definitely be taken care of. Once you do that, you can clearly see here the AC depth has reduced, the hyperopic shift has decreased, so patient is almost now the refractive surprise, whatever he had due to the capsular contraction has been taken care of. Sometimes it will be so fibrous, the capsular contracture, the laser may not be amenable. You may have to go for a bimanual technique of using a forceps, and you cutting the scissors has to be taken to make an opening and make a radial nix and enlarge the anterior capsular opening. So based on the degree or severity of the capsular contracture, we can divide whether to use a laser or a surgical maneuver or what you want to do. But while peeling this membrane also, one should be very careful not to pull too hard, because if you pull too hard, sometimes you may damage the zonule and you may end up with exchanging an IOL. So it has to be meticulously done. Other thing one can do is using a femtolaser. If you got an access to femtolaser, you can give a relaxing incisions on the capsular contracted capsule, and you can get away with the capsular contracture. So vigilant observation is the key in detecting and preventing it. Identify all high risk cases, select the appropriate IOL, consider CTR and CT segments if required, suture them. The meticulous surgery with capsular lens epithelial cleanup sometimes may help. Laser surgery multimodal approach sometimes has to be considered based upon the degree of contracture. Now moving on to the second problem which we tend to face post-operatively, that is a capsular bag distension syndrome. It is a rare complications. It is nothing but a presence of a turbid fluid between the IOL and the posterior capsule. It can be either seen intraoperatively, early post-operatively, or late post-operatively. Early post-operatively, most often it occurs due to the residual OVD or viscoelastic device, and late because of the incomplete removal of cortical cells, the residual cortical cells undergoes metaplasia and causes proliferation and leads to the fibrotic sort of a accumulation, which leads to the late capsular distension syndrome. As I told before, either it could be fibrotic, which is seen in the late stage, inflammatory, which is seen in due to the anterior chamber reaction, and the presence of OVD. So treatment for each is different. Fibrotic type, probably you have to disruption of the capsular bag using a ND-lag helps. In an inflammatory type, we may have to do a NSAID drops, and in a non-cellular or a OVD, disruption of the capsular bag and aspiration of the residual OVD may clear off the thing. Many classifications have been used. The clear cut, we can classify into 4 types of capsular bag distension syndrome. In the first type, there will be transparent PC, but liquid will be there in the capsular bag. That liquid becomes much more homogeneous, but still it is transparent. As you move further, it becomes semi-transparent and then becomes opaque and turbid. In the late stages, you may have a PCO with a sommering ring in late stages of capsular distension syndrome. Some of the differential diagnoses you should keep in mind when you're treating a capsular distension syndrome. One could be phacoanaphylactic uveitis, posterior capsular opacification, P. acne associated chronic endophthalmitis, pupillary glaucoma, and nowadays with the use of hydrophilic IOLs, which becomes opaque and sometimes can mimic like a capsular distension syndrome. Anterior segment OCT, definitely a useful tool which gives a clue to that where is the status, what is the status of the PC, how much amount of the fluid is present, and other things can be easily documented. So treatment, as I told before, either observe in initial stages, do an anti-inflammatory drops, or do an NDAG laser capsulotomy. Sometimes you may have to do a slit lamp needling to open up this fluid and aspirate it. In late stages, one may have to resort to the pars plana vitrectomy and posterior capsulotomy. So pars plana vitrectomy, what are the advantages is, one thing is if you do a YAG, sometimes this milky fluid can enter the vitreous cavity and can cause an inflammation, which will be taken care if you do a pars plana vitrectomy with capsulectomy. So whatever the turbid fluid which enters the vitreous also will be taken care. So the chances of inflammation and other things are less. And once you have entered, you can give an intracameral antibiotics also. But the only thing with pars plana vitrectomy is a more aggressive procedure, sometimes can have complications. Sometimes what happens if the PC is clear, you can just make an opening in the PC to get rid of the thing, as I told before. Sometimes what happens, the PC will be clear, You don't want to touch the PC, then what you can do is go to the periphery of the iris, do an iridotomy. Through the iridotomy, hit the anterior capsular opening. So whatever the turbid fluid is there from the capsular bag comes in front of the IOL, and you can just wash it. Like this is your peripheral iridotomy has been done, the turbid fluid comes into the anterior chamber and you can just wash away with it. This is a simple way of treating with Nd:YAG laser capsulotomy. Where you do a regular capsulotomy with a posterior capsulotomy, you can do this thing and get rid of the turbid this thing. Sometimes what happens, simple maneuvers like releasing the adhesion between an anterior capsule and the lens and tapping the IOL itself will release the fluid. Like in this case, go there, separate the adhesion between the anterior capsule and the IOL, just tap the IOL, whatever the fluid is there will come into the anterior chamber. You need not touch the PC. Once you have done that, you can easily wash away and get rid of this problem. Thank you for your patient hearing.
Excellent talk, Sunil. I was just, yesterday I was part of one of the debate, Femto versus Zepto.
Okay.
I was one of the panelists. So I was just thinking about your presentation. You said that one of your slide, whenever there is a very thick and this one, the Femto is not a bad option also. You can do it. I think, why can't we even think about Zepto?
Zepto, the thing is, it's work on more of a cautery mechanism. Sometimes it's uncontrolled in some of the things. So it's precision wise, if you got an access to Femto, it's the best thing. But when compared to the manual option, Zepto is any day better. But the studies have shown the manual CCC stability and the contracture aspect, if you study in a long term, is as good as Zepto only.
No, but wouldn't the Femto have an effect on the IOL there?
No, you have to precise plane, you have to choose it. Depth.
But the one more technique you told about the capsular distension. In front of the slit lamp, you do the needling in the needling. But whether the aseptic precautions really.
No, nothing like that. We tend to do many maneuvers in the slit lamp, like we do rebubbling for many of the lamellar cataract surgeries. We do many of the intracameral. We see, for example, whatever the P. acne endos we tend to see when we initially manage, we tend to give intracameral or in the bag antibiotics in the OPD itself. It's not that it cannot be done, but all sterile precautions has to be taken. Unlike in Western countries, we have got an access to OT everywhere. We take all patients to OT. In a Western countries, if you take OT, the charges and other things is very expensive. So you need to stick on to the many of the OPD procedures. It could be intravitreal injections or in the open needling procedures or rebubbling. Many of the things has to be done on an OPD basis rather than an outpatient, the operation theatre basis.
Thank you, Dr. Sunil.
Thank you.
Now call upon Dr. Krishna Prasad Kudlu for his presentation. Dr. Krishna Prasad Kudlu is somebody who needs no introduction, chairperson of the ARC. We get emails for him from the ARC proceedings every day. He's also the president of Karnataka Ophthalmic Society. Over to you, sir. Sorry. Thank you, Dr. Sharath, for correcting me. Chairman proceedings, not ARC.
Thank you, Dr. Vikram. I think in continuation of troubleshooting post-cataract surgery, so I'll be talking about how I tackle the post-cataract surgery refractive surprise. So what exactly this refractive surprise, which is the failure to achieve the intended post-operative refractive target. It can even cause anisometropia or dominance switch, which is a source of a patient for dissatisfaction. If you see the benchmark standard, what has to be, around 85% of the eye should be within 1 diopter, 55% within 0.5 diopters of target spherical equivalent refraction following a cataract surgery. So always prevention is better than cure. The best way to manage refractive surprise is prevent it. One important, accurate biometry, a constant optimization, selecting a proper intraocular lens formula, and also avoiding wrong lens implants. So once there is already refractive surprise, you should identify the cause. First, the formal subjective refraction is essential. Thorough dilated examination to identify the surgical causes, like look for tight corneal sutures, whether you place the intraocular lens in the sulcus or in the bag, or there is a distended capsular bag due to retained viscoelastic that can also cause myopic shift. Sometimes presence of any corneal pathology like corneal scarring or corneal edema which can influence the refractive outcome. Of course, postoperative cystoid macular edema even can cause a hyperopic shift. So, now review the refractive history and take out your biometry values also, the IOL selection process, and also look for the surgical record. Whether wrong patient biometry has been entered, see for any transcriptions error, selecting the lens from the ACIOL column, that also important. Incorrect A constant, also incorrect formula what you have picked for that particular patient. Then you should check for the axial length by repeating the biometry. You should check for abnormal keratometry. Sometimes what happens, the presence of high case or astigmatism, that means you might have missed the pre-existing keratoconus in that patient. If there is no error, the refractive surprise can be attributed to the effective lens position, and similar error can happen in the fellow eye too. So, coming to the management, this is very important. Whenever there is a refractory surprise, always better to openly explain to the patient an apology. But this is not a declaration that you have done a guilt, but you have to tell him that it has been happened. Let us see how we are going to manage. Sometimes best way, you take a second opinion from your fellow colleague, that makes their tension little bit on the lesser side. So, what are the options? So, doing nothing is always a better option. Many refractive surprise do not require a surgery. Suppose if you leave behind some low myopia, we can convince them that they will have a very good near vision. Suppose a patient who has already worn glass in their life may be willing to continue wearing glasses. Sometimes when the patient already wearing the glass, when they come to with the refractive surprise, if you won't mention them, after 1 month of post-op, just give them the glass, they will be very happy. They will be keep getting more number of patients to you. But the benefits and risk of intervention, this also you have to explain to the patient very well. So, coming to the management side, again correcting the surprise depending upon the comforts of the surgeon, which intraocular lens has been used, how long it has been since the lens was implanted. This is very, very important. So, first, if you have got a already retained viscoelastic, this is the only indication you can do a early YAG capsulotomy that can disperse the viscoelastic and allow the anteriorly displaced intraocular lens to move posteriorly. Coming to the corneal refractive surgery, I think this is one of the, I can feel one of the best option, because I do have got a examiner machine with me. But whenever you think about, okay, you want to do corneal refractive surgery, whenever there is a residual refractive error, always better to wait till 3 months. In spite of, I have done in 1 month also, but now I am telling you to wait for 3 months. For a small amount of residual refractive, or even you can do PRK, or if you have got a femto platform, femtoLASIK can be done. So, in older patient, it is always better to do a PRK, because they might be already having dry eye. You should not be again increasing that dry eye problem. For younger patient, if they are having around a residual error of -3 or -4, femtoLASIK is one of the good option. So, coming to the ablation profile, lot of studies has showed that wavefront guided treatment gives much better results than the topo guided treatment. According to the Generita et al. Evaluated the outcome of wavefront guided treatment with iris registration after implantation of different multifocal intraocular lens in 27 eyes of 19 patients. They found that patient already been implanted diffractive multifocal intraocular lens, so they did very well after the wavefront guided treatment. So, always LASIK seems to be very safe if you already done the YAG capsulotomy, because once you do the YAG capsulotomy, what Dr. Sunil had shown, the IOL exam sometimes has become difficult and has got a greater risk, because you may not be promising the patient that you will be putting again within the bag. Once the LASIK flap has been established, then additional optical adjustment also can be performed successfully. Normally what happened in femto especially, I do have got a Visumax, where the amount of intraocular pressure it puts over the cornea is around 25 to 30 millimeters of mercury. So you can make the flap, you can do the with the excimer laser, you can polish the whatever the power. Suppose again any problem happens, you can lift the flap back and you can again re-enhance the treatment. So what are the limitations again for laser vision correction? If you have got a high refractive error, again you can't do, and even patient with a low corneal stromal thickness also you cannot do. Of course, the very important thing is you need to have this excimer machine in every clinic, which is not going to be possible in this era, and even extra cost to the doctor and not for the patient, because you cannot charge, especially if you are having this kind of problem, you have to do it free of cost to the patient. Coming to the intraocular lens exchange or piggyback, so of course it is effective in reducing the high degree of spherical error, because lens exchange never going to alter any corneal surface, do not change the corneal refractive power. So you don't require any special setting what we do with the excimer laser. But add-on sulcus lens now have been becoming more and more popular, something called a piggyback lens, which can be implanted in the sulcus over the original intraocular lens. As this corrects the manufactured refractive error, the power of the you need not have to know about the power of the original lens. So these piggyback lenses are less accurate than, of course, than the laser refractive surgery, but good for, especially for high degree of error. So always I avoid the risk of IOL exchange, as those who have already with the ocular surface disease and which is there not suitable for laser refractive surgery too. So the problem with only with these piggyback lenses, I have done a lot of piggyback lenses in the past, but some of the patients come to us with something called pigment dispersion. You may have to tackle them with a long course of steroids. So of course these piggyback lenses, especially someone from the Rayner, these are quite expensive. I think you have to bear those costs also. Coming to this sulcoplex lens, which has been become more and more popular, which is a spheric pseudophakic supplementary intraocular lens, we put it in the sulcus, which is especially help to correct the residual post-operative refractive error. Because once one patient has been underwent multifocal lens in one eye, had come to me, said that my near vision is not good, I don't want any sort of other procedure apart from this, then I have to really pick a trifocal platform in this sulcoplex and implant it in the other eye, patient doing very well. So these lenses are a little bit helpful even for those who really doesn't want to wear the glasses. In conclusion, if you nutshell, I want to tell, laser vision correction has been shown to be a viable, non-invasive and accurate procedure to correct the emmetropia after cataract extraction with IOL implantation. Lens-based procedures, IOL exchange or piggyback lenses implantation are possible alternatives. Piggyback intraocular lens, technically easier, but more accurate than the IOL exchange. You need to remember that, which is better indicated cases with extreme emmetropia, corneal abnormalities, and when there is no available of examiner platform is available. Thank you.
Thank you, sir. By piggyback lens, which lens are we talking about? Sulcoflex or?
Sulcoplex.
I think now that we have our phakic IOLs in very low powers, they are the easier option.
Yeah, this is one of the things. Again, see, from IOCare already designed a phakic lenses which can be implanted over the in the sulcus.
Start from one day up
now. But again, I have experienced in a couple of patients with same lenses, pigment dispersion is much higher compared to these what I told the sulcoplex lenses. Okay. So I think whatever the phakic lens, I think we have to keep in the last option. Okay. If you are having a very high refractive surprise, we cannot do the IOL exchange, then I think probably the phakic lens is the best available option. Because what you do, if you are already having the astigmatism, you are putting in the sulcus, sometimes these lenses may rotate. Again, patient may come back with you some amount of astigmatism, then you have to re-rotate, or you may have to do the exchange of that phakic lenses.
Thank you. Now we have Dr. Shamant Shetty, who will be talking on decentered IOL and IOL tilt. Over to you, Shamant.
Thank you, Dr. Vikram, and thank you, everyone. Thank you, AS, for this opportunity. So I'll just talk about decentration and IOL tilt, which happens here. Basically, it happens because secondary to a complicated cataract surgery. A main cause for IOL tilt is for our capsular fibrosis, IOL haptic positioning, suturing errors during our SFIOL times, scleral positioning, again when you're trying to planning for an SFIOL, haptic breakage, or you go undergo if the patient has undergone a previous retina surgery. Mainly, and decentration occurs during your surgery when you attempt, like you have done a very large rhexis, zonals are weak in one quadrant, you have not identified a PCR, one haptic is in the bag and another sulcus. Days or weeks you notice again the lens being displaced because again in a spontaneous IOL, especially in your torics, it is malrotated because, again because of your zonalizations. Months or years, again in case of trauma, pseudoexfoliation or in Marfan's. So what happens is this 1 millimeter of decentration or your 5 degree of tilt, this basically results in your defocusing, your vision quality decreases, and there is aberrations which are formed. So this affects is like if at all the patient has little bit of large pupil, the effects on glare, starburst, double vision, these are all are present there. So how do we like evaluate the decentration? So we have to see like what is the degree of decentration, symptoms, and the accompanying complications with that. Mild if the optics is covering more than half of your pupillary space. Moderate decentration if it is covering less than half of your decentration. Subluxated if it's already one half is in the pupillary space. Luxated if it's already down. Symptoms mainly, as I said, your vision quality decreases. Glare again is related because of your IOL haptic causing again monocular diplopia, floaters. Complications include your inflammation, your IOPs increase, vitreous incarceration, red CME. So how do we measure this? Mainly like the simplest is like when we are operating the microscope, like we see the light reflection, that is better to focus. So that gives you like invariably like it's simple, but the right reflection gives you a fair amount of idea how to go about it. Ultrasound microscopy gives you a clear idea about the tilt and the decentration, but when you are it is basically again you are going to use a contact method. So this might again deform the eyeball, which will give you a wrong result. Sheen plug is very fast, it gives you an accurate result, but you need what happens is you will need to dilate it, and you will need a more than 6 millimeter pupil to get a good correction. ASOCT, which is again the non-invasive and non-contact imaging, gives you a tilt at the horizontal direction and the vertical direction correctly. So all the newer generation OCTs automatically will give you a view of it. Eye trace again is based on your ray tracing aberrometer. It's the combines both your wavefront and as well as placid based. So this in your higher order aberrations like glare, halo, which cannot be quantified by refraction is got here. Modulation transfer function, which is there in that, it gives you a clear picture of an entire optics of your eye. So that differentiates and gives you how much, what is happening in the cornea, or is it the problem in the lenticular part. So if at all, like how we are seeing here, we are seeing up, like we are seeing the amount of astigmatism, the amount of aberrations which is there. So we know, like again as we see here, this is how much of amount of the refraction which is left. So best way is like when you explant it off and put another lens there, all these things are cleared off. So how do we manage it? Basically you can start off by giving glasses and you just try to observe it, and if the patient rejects, then you can plan for something else. So when do you want to intervene it? You need to see again like how much it is decentered, what are you going to do, and like if at all it is going to keep this going to happen, how are you going to manage it? So if at all in case of decentration, if you have already noticed a PCR, better again you do an anti-vitrectomy. If you are seeing the lens being already luxated, try to take it out, get a VR opinion, make sure everything is stable, and then go for your second plan. So again, the outcome of all these things depends upon the preoperative macular function, how much the complication is there and how much we can handle it, and the complication at the final end of the surgery. So mainly now we can start by try to reposition it, especially the torics. How much ever, like within 1 to 2 weeks you are coming to know like how much it is rotated. So it is better that you intervene then and there. If at all now your lens is not placed in your bag correctly, you can try to go in then and there, try to place these things. Sulcus, if it already you are known that your lens is not correctly placed there. Bag placement in case of your capsular support devices if possible. Exchange, if the risk is like again you plan it when it is really bad, you have to go explain the risk of your corneal endothelial trauma and again your repositioning things. It's better that time you use your high risk. Exchange when you are doing it, better to use again your IOL cutting forceps, cut it into correct halves and then take it out. If you're planning for an SF, make sure that you are making your point of fixation very correctly and markings. And again, when you're suturing, like how tight or how loose, you have to check it out. So summary, like evaluation management strategy must be planned. Do not inject your broken haptic when you're already seeing it that you can explant it then and there. Do not misjudge your IOL placement also. Decentration has a greater impact than tilt on reducing your visual quality. Proper placement of your secondary IOL also is very important. My take-home message would be negative negative impact on the optical performance and the patient satisfaction is equally important. When you have the availability of your rhexis markers and toric markers, it's better to use them. IOL decentration more than 1 millimeter or a 5-degree tilt has to be addressed. Visual performance of multifocals and torics are profoundly affected, especially in your premium patient when you use this in case of decentration and tilt. Yeah, thank you for your time.
Thank you, Dr. Shaman. But a couple of points I just wanted to tell you. See, now the incidents of, I think, Sharath, you can plug your presentation. That before that, we need to have some discussion regarding this. Most of the people wants to go for premium IOL practice. So to have premium IOL practice, sometimes this decentration, when you see like post-operatively patient coming after 1.5, 2 months, when you see the center part of that multifocal will be on the shifting towards the pupillary margin, you will see a lot of rings around. But you might be thinking that, okay, I have done the surgery very well, but why this intraocular lens has been decentered also? There are two possibilities. They might be having a larger capsule bag itself, and also they might be like whatever some people might have done under the block, where whatever the once the eye is anesthetized, wherever it gives the Purkinje image may not be that true. These are the 2 points. But one equipment, no financial disclosure, really makes us so easier is eye trace. Because eye trace gives you exact value of angle alpha and angle kappa. So if you think that, okay, if the angle alpha is more than 0.6, then we better to avoid these premium intraocular lenses, because if you are having a large angle kappa, especially angle alpha, even angle kappa in hypermetropy, then the chances of this decentered IOL will be much, much higher. Rather, satisfying this patient will be much difficult. Again, there are one more aspect I want to highlight here. When you are going for any of these premium IOLs, okay, think that already patient angle alpha is larger. See for other eye also. Still patient wants, always you can play around with the both the eyes. That means nowadays for any premium cataract surgeries, knowing the dominant eye of that particular patient is very, very important. Always you have to be dead on with the intraocular lens power calculation for the dominant eye, but non-dominant eye, there is some amount of any decentered lens or any more rings even in the pupillary margin. If you see, there will not be any much complaint by the patient, but you have to be dead on. That's why even I tried in my mother, one eye I put a monofocal on the dominant eye, and the non-dominant eye put a multifocal. Even she had a very large pupil, she never complained because her dominant eye is very happy, she could able to see for distance. Always knowing dominant eye is very, very important. And one more point, lot of people have been tried with something unique lenses. My friend Dr. Sri Ganesh, he had been tried with something lens which can be glued within the bag. So some of the patient with a large angle alpha, when you put it, it is not corresponding with the Purkinje image. You glue within the bag and make it centered, which is, if you ask for any of the cataract surgeon, is the most difficult job in that time. Still he tried and he was very successful, gluing the IOL in the bag or in the sulcus. That also makes some sense, but it's all difficult. Again, decentered IOL is a one big challenging. Of course, again I am telling you, if you are having decentered, again give the patient for 3 months, give for neural adaptation. If neural adaptation does not occur, then all this management is.
Yeah, you'll need to plan for the how to assess it. If the amount of decentration, especially, will not come to know. The thing is, like if you're trying for your torics, it's better that you go then and there earlier. because later when you use it, your capsule becomes contracted. So that time when you go to rotate it or to handle it, it becomes problem.
Actually, I had a patient actually with the toric trifocal I have done, patient with a very high myopia. The biometry was perfect, but after putting these lenses, the lens rotated within the bag. Then what I did normally, like what David Chang say, that you have to keep the patient for 1 hour, then get in front of the slit lamp again, see, then you rotate. I rotated, then called the patient after 1 week. Again the lens rotated. Then I took the patient back into the OT. Then again it was rotated for another 1.5 cylinder. Then I said that I just kept quiet, but I kept the patient like for 3 months follow-up. Then he was quite happy for his near vision, and other eye was luckily the lens not rotated and I could able to get through the. So these are the small problems I think you have to be very, very careful. I thank Dr. Shaman for a wonderful talk. Yeah, there are different types actually to know the dominant type. One you have got, make a small aperture within the both the hand. You put it around 636 in the Snellen chart. Tell him to see through the aperture through this thing. Then tell him to get this both the hands together. Then whatever the dominant eye only, you will try to focus. Then again you tell him to take back. You try to close each eye. When you closing the dominant eye, suddenly you will tell that I cannot see anything. Then when you closing the non-dominant eye, still he could able to see. That means you are checking the proper time. There are, even if you check for your shooting test also, always you do through your dominant eye. You can try from here also. So knowing the dominant eye in every patient is very, very important. So in continuing with the unhappy cataract patient, we have all dealt with how we deal with the refractive surprise. I spoke about the laser vision correction. Dr. Vikram told about dysphotopsia is one of the complication which we can tackle them. Shaman talked about the decentered IOL and IOL tilt, and Dr. Sunil Galekar spoke about how you manage the capsule contracture. But there are other problems also for patients' unhappiness. Most important problem I think everybody keep in their mind is which is associated with the retinal pathology. We have got a senior vitreoretina consultant from Prasad Netralaya, would be Dr. Sharath Tegde will be talking about how I deal with the patient with the associated retinal pathology. Over to you, Dr. Sharath.
Thanks to Dr. Krishna Prasad sir and AIOS for giving this opportunity. So once the anterior segment surgeon have seen that patient is not happy, they will try to look for any refractive surprise, dry eye issues, IOL tilt, and when they see from their side there is no issue, that time they remember us saying just have a look on retina once something issues may be there and all. So till then they won't remember us. So there can be various reasons to cause a decreased vision due to the retina pathologies. It can be of two types. It can be subnormal vision, where even after doing a cataract surgery there won't be improvement the next day, and sometimes there can be initial improvement and after few days there can be again decrease in vision. The other issue which can be there is floaters. It can be recurrent uveitis or there can be a posterior vitreous detachment. So for subnormal vision, there are various conditions which can cause any issues in the retina can cause subnormal vision. But the most common being macular thickening due to any vein occlusions, diabetic macular edemas, and optic neuropathies and AMD. We have to keep in mind. And most important, where the vision had decreased after few days after cataract surgery, we have to think in mind of postoperative CME and where the diabetic macular edema has worsened. So I'll just go through a few case scenarios. So this is the one patient who after the cataract surgery, the patient for first 3 weeks the vision was 6/6, then the patient vision decreased to 6/24, and when we saw the patient clinically you can see the foveal reflex was dull, otherwise the fundus looks absolutely okay, and when we did the OCT we can able to see the presence of cystoid macular edema. So this is a classical case of postoperative CME where usually we see after 4 to 6 weeks of cataract surgery, and usually it is associated in a patient who has diabetic or who has any postoperative complications or any previous history of uveitis or diabetics. If the patients are there, that time we see this postoperative CME. And it is not very difficult to treat. Most of the postoperative CME will resolve by itself by 2 to 3 months, but nowadays we won't wait, we go for steroids. Usually we give posterior subtenon steroids or like a peribulbar block also we can give the transeptal kinocort injection. Also the nepafenec, they say it will work. As I told you, even the placebo will also work for 2 to 3 months. If it is not resolving by these things, we can give intravitreal steroids or anti-VEGF also. This is the one patient where I have given like a transeptal kinocort, and after 10 days we can able to see the macular edema is very nicely resolved. So diabetic macular edema, as we know, it is always associated with the increased risk of worsening of diabetic macular edema post-surgery. And they have almost shown some studies where 22% of diabetic patients will develop macular edema. So this is the one patient where the patient has underwent a cataract surgery where the mature cataract was there. When we see afterwards, there was a presence of large cystoid macular edema which can be seen. And the UK trial which has been done, which has also shown after the cataract surgery, the diabetic macular edema increased in all the grades of retinopathy in next 6 months. It's because various reasons. The one and foremost is where the patient doesn't have knowledge about these retina problems. They think once the cataract surgery has been done, the eyes, everything is fine, nothing issue will come, and they'll forget about the diabetes and our general condition. And after 3 to 6 months, they come and say, sorry, we have done the cataract surgery, everything was good, now my vision is decreased. So when we see and go back, we can see the systemic conditions are not normal and there will be diabetic macular edema. So the another study also showed that there is a significant increase in the diabetic macular edema thickness post-cataract surgery. It may be because of the inflammation and also the systemic problems. So here this is a one case where you can see there is a extrafoveal thickening which was there with the presence of hard exudates before the cataract surgery, and when he came after 2 weeks for the follow-up, we can able to see there is the presence of neurosensory detachment also, and some intraretinal fluid also was noted. The another most sometimes we may miss is the proliferative diabetic retinopathy, where the patient may have a thickened hyaloid, and this may also be a reason of decreased vision. And another important thing which easily can be missed is the epiretinal membranes. So where the clinically, when there is an extreme cataract, you may be missing the diagnosis when you see in the indirect. But the most important investigation what I prefer to do is OCT before any cataract surgery, which may pick up these small conditions. And many studies have shown that the ERM per se won't progress in the cataract surgery per se, but the macular thickening due to edema can progress in the next 3 to 6 months. The another which easily can be missed is the vitreomacular traction, which may require surgery. And sometimes post cataract surgery there can be a posterior vitreous detachment which can happen, and this posterior vitreous detachment can lead the vitreomacular traction to convert into a macular hole. In this case, where you can able to see a small macular hole which has progressed in 2 weeks to a full thickness macular hole. This is the preoperatively the patient had a macular hole picture. And the most important thing what nowadays we see has all the patients are more than 60 years, we see age-related macular degeneration, and especially this wet AMD, if it is type 1, it is easy to miss out. So most of the times you should see how the foveal reflex is, either any drusen's are there or not, and yes, preoperative OCT being most important. Dry AMD also we have to keep in mind, where we should clearly explain to the patient the central vision is not going to improve as you are expected in the patient who has ARMD conditions. So does the cataract surgery will progress the any ARMD changes? So many studies have shown that cataract surgery per se is not going to change or worsen your age-led ARMD conditions. It just the preoperative and postoperative vision quality will be less, but surgery per se is not going to change the treatment or the condition of the ARMD. And another few things which can be missed out is like a old vein occlusions, where fluorescent angiography will show you there is a small tributary vein occlusion which can be there and which can be easily missed out. And yes, chronic CSR, because the patient may not be given the history properly, and so subtle RP changes which can be missed out easily. And yes, if you do a fluorescent angiography or a fundus autofluorescence, you will give a very nice picture, and definitely OCT will be showing the foveal thinning. And other things, when we know when the patient is under rheumatoid arthritis or any other systemic conditions, and sometimes we may forget to ask histories, what medications they are, and this becomes most important because many patients may be there on HCQs and which can lead to HCQ toxicity. Like this, in this patient, you can able to see there was the foveal thinning can be seen like a bullseye maculopathy, and in the OCT is showing like a flying saucer sign. Similarly, you should ask any tamoxifen toxicity like thing, any drugs are they using, this becomes most important. And yes, the dystrophies we should not forget, like in this picture you can see a retinitis pigmentosa which is there, they may not give the history, and after the surgery when you see the fundus and all clearly, they can see the RP like picture, and also sometimes there can be presence of cystoid macular edema. And once you finish the retina, everything looks normal, everything is fine, then we should not forget the optic nerve pathologies, especially like NIN, where there will be like a temporal disc pallor which will be there, which can be easily missed before the cataract surgery. and advanced glaucoma and certain white draw syndromes also which can be there. So this is the one case where the patient had developed NIN, and after few days there was the thinning of the optic disc pallor which can be seen, which easily can be missed before cataract surgery, and this becomes the important of evaluating pre-op for RAPD, or how the patient is complaining the blurring of vision, what is the type of blurring of vision to ask is important, because NIN or any ischemic optic neuropathies, as you know, they will be having a field effects, but in the cataract surgery they will be having a cataract issues, there will be generalized depression will be there. So another dreaded complication which you always keep in mind when it comes to recurrent redness or any pain is postoperative endophthalmitis, like a long-term delayed endophthalmitis. You can see here the patient was very happy for a few days, then slowly this grayish membrane started coming, it's like a ball-like thing, and these are like a fungal endophthalmitis you should be very, very careful of. And recurrent uveitis, yes, sometimes when this IOL is in the sulcus or some remnant cortex can cause the recurrent uveitis and recurrent redness, which the patient may be complaining regularly. So these are the certain incidents what they are shown, like approximately 1 in 400 cataract surgeries can develop recurrent uveitis. Floaters, these is a very commonly in a day we will be seeing 5-6 patients where they say cataract surgery is very good, but still I am seeing something is moving in front of my eyes, floaters and all. It's very common, and if you have any complication, we can have some nucleus lens fragment which may be remaining out, and if it is not resolving, we may need to do a vitrectomy for these conditions. So overall, what I can say is like proper history of duration and previous treatment becomes important. Complete evaluation including RAPD has to be checked, and preoperative OCT for all the patients, which will help to detect a retinal problem, is very important. If the patient has a mature cataract, do a B scan in all the patients, and early referral, for example, in the case of patient has diabetic retinopathy, and then it's better to give steroids or anti-VEGF before doing a cataract surgery, so that the post-operatively the patients will be happy. Thank you.
Yes, madam, you wanted to see the dominant eye, you were just asking, I'll just show you one video. Will you just...
Thank you, Sharad. The ERM and all,
Yeah,
sometimes
yeah.
we'll...
Just a minute, Vikram.
Yeah, okay.
So I'll just show madam about the... See, this is after refraction. I am trying a dominant eye for this particular patient. So I tell him to make a small aperture in the hand. I am telling him to get near to his eye. Then this patient has got a right eye dominant. 90% of the patient has got a right eye dominant. Then you close each eye and see. Then which is the dominant eye. Then you proceed. Okay. So this I just wanted to share with you because she had just asked. Thank you.
Yes. Sharad, sometimes if it's a very Brunson cataract or the PSC is very thick, even though we do a routine OCT, we might miss small things like a faint ERM or a VMT.
Yes.
Are there any other tips to pick these up preoperatively in the presence of a fairly advanced cataract?
So most of the times when you're doing an OCT, if there is a thick PSC, what we do is like we will see where the clear space is there. So from there we can able to pick up these subtle issues, and other than that it's very difficult to identify. Usually when you're doing an indirect ophthalmoscopy, for example, if you're using if you have a PSC, there is certain option is there in the downside saying a small pupil and a central opacity pupil. If you change that and if you try to see the retina, you can able to see. And another important thing is, if you are able to see some amount of retina, try to change it to red-free light and see the retina. Red-free light. That time the foveal reflex and all can be clearly seen, whether it's there or it's not there.
Okay. Thank you, sir.
So I think any doubts? I think we covered almost unhappy cataract surgery. Madam, ask me.
Yes, ma'am. What we can do is a detailed dry eye workup. Again, start with the Shermer's test. Many patients, not just inflammation, but they might have a significant meibomian gland dysfunction also. You have to treat that also, because in what you see, congested vessels are just on the surface. Underlying maybe multiple pathologies, one of the important being meibomian gland dysfunction.
Rule out
Ag-
connective tissue disorders also, ma'am.
Hmm?
Connective tissue disorders has to be ruled out, like rheumatoid arthritis, all those things, sir, because it may extremely cause dry eyes and episcleral. You should rule out on rheumatoid arthritis and condition.
There are a couple of tests, madam. I think we are just going for accurate results. One of the equipment that yesterday has been launched in a AIOS stall from Narayan Netralaya called a biomarker kit. Actually, we take out a tear fluid and we send for a different enzyme analysis. So some of the patients with a increase in the MMP level or interleukin 2 also sometimes may have this kind of problem. So first evaluate the dry eye, evaluate the tear fluid, and also do all the blood test just to rule out whether the systemic, to rule out any connective tissue disorder. Then you may come up with the results. But what they say, that yesterday I was there in that stall, by evaluating the tear film itself, most of the things you can know. Connective tissue disorder also you can find out in the tear film analysis itself. Thank you.
Another thing, some of the residents, they put the lens upside down, but ultimately the refractive error there was not much.
Unless it's a three-piece lens with an angulation, a single piece, most of them don't have an angulation, so it will work. Yes, if it's a three-piece lens, it has an angulation. Some of the single pieces lenses also have some angulation. If there is no angulation, there is no change in the effective lens position, therefore there won't be any refractive error.